All right, moving down the body, let's say we have a sucking chest wound. So we come in, person's presenting with difficulty. Once again, we're going to run these as scenarios, right? So you come in and say, okay, you've arrived on scene, report of a gunshot, the scene is secure. We got one patient, the patient's laying or sitting in a chair, he's kind of clutching his chest, having difficulty breathing. You arrive on scene, your BSI, scene safety, you've done all that. You start interviewing the patient. How you doing, sir? You arrive up there, and then next thing you know, he's having difficulty breathing, and we got a little bit of blood that's coming down between our fingers. So we're identifying at this point we've got some kind of issue we want to expose. So as we expose, we encounter a sucking chest wound. First thing we're going to do with a sucking chest wound is put our what? Gloved hand over that. Is that a form of treatment? Yes, it is. Once I put that gloved hand over that, okay, what I can do is I can look everywhere else to see if there's any kind of a what? Exit wound. Any kind of penetrating trauma, all right, we want to make sure we verify whether there is or is not an exit wound, okay? So in this case, it's a gunshot wound, occluded. We don't see anything else. We'll go ahead and treat that appropriately. So treating that, there's a couple of ways we can do it. If you're using the old conventional method, what we're going to do here is you're going to take, once again, the occlusive dressing. You want, once again, 2 inches all the way around, and when we put this on here, we're going to put that, once again, take a towel or something, wipe it clear, put this on it. We're going to tape 3 sides down, okay? We're going to get ready to take the 4th. We're going to have him exhale forcefully. Now remember what's happening in there, that air is building up, the fluid build up kind of thing. We got to try and clear that pleural space because that penetrating wound has done what? It's created a hole in the lung, which is letting air into that pleural space. So we have to get that air out of pleural space. And then what happens is he's breathing in, of course, if air comes in from the outside, it's not letting the lung inflate. So by putting the occlusive dressing on here, we're sealing the outside cavity, so now hopefully when he's breathing, we can get that lung to reinflate. Okay? So by putting this on here, we're going to have him exhale forcefully. When he exhales forcefully, we're trying to get as much air out as we can. He might have to do this 2 or 3 times. Okay? Not necessarily that one exhale, and that's it. When he's on exhale, that's when we're going to seal that 4th side. And like I said, it may be 2 or 3 times exhale before we can do that. So we're actually taping all 4 sides right there. Now we're going to go ahead and verify that that is indeed working, and his lung is kind of reinflating. He's able to breathe a little bit better, and we're going from there. And when you have this, if you look in the very back of it, back here, this is where your seals are. There should be 2, okay? You have to have at least one that is a vent. Now understand in the vent one, you're going to have 2 in there. Okay, one is a vented, one is a non-vented. And then the other package, this one just has, just contains 2 seals. Okay, but you have to have at least 1 vent. The idea here is that we can get this out, and if there is multiple wounds or air coming out different places, the one with the vent has the circle in it, okay? So where that circle is, we're going to peel this, and this goes back to old school. You got sticky side down, okay? The sticky part is going to go down. All right, and in this process, we want this little hole to be right. So let's say it's right over here, the Z. This is where our hole is. We want to make sure that that circle goes right directly over that. Make sense? All right, so we're going to seal that. That's vented, so as pressure builds up in there, once again, not allowing, if pressure builds up in the pleural space because it goes through the lung into the pleural space, keeping that lung from inflating. Once again, once that pressure builds, it'll vent, and that's the whole idea. The other thing is these are going to bleed, so through the vent you could also get some of that blood out. All right. The other thing is wherever we find a subsequent wound, we're going to go ahead and put the other one, the non-vented one, in those other areas. So there's only one place for everything to vent. Everybody good with that? So this is the option that we prefer now. We're going to try and use these instead of doing the tape. They're going to seal a lot better because there's a lot more surface area. Plus they self-vent. It allows us to focus on the patient a little better, not have to try mechanically vent things and time it with the patient. It'll do it when the pressure builds up.